Hey, hello, everyone. And thank you so much for joining the SBC Working Group General Call. My name is Grace Miheso, and I'm a member of the SBC Working Group Steering Group. I just want to extend my welcome on behalf of the team to this call. Today's call will be interpreted in English, French, and Portuguese. Please select your language for interpretation now by clicking on the interpretation icon at the bottom right of the screen and select your language. I'd also want to extend our sincere thanks to the RBM Partnership for providing today's interpretation. You can follow along with today's presentation slides in English, French, or Portuguese by going to the link on the slide. The link is also in the chat. If you haven't done so already, please introduce yourself in the chat box now, sharing your name, affiliation, and country. And I'm already seeing so many familiar faces, and it's so nice to catch up with you after such a long time. Welcome, everyone. The agenda for today's call includes SBC Working Group updates. We'd also have a presentation on Bridge the Gap SBC findings, then best practices and learnings from Zambia in prioritizing SBC. And I'm sure that both these presentations will really exciting presentations and will give us some real directions on how to move forward. We'll then have a question and answer period, followed by closing remarks. I will now pass on the floor to Elizabeth Chiende, the SBC Working Group co-chair. And welcome again.
Thank you so much. Thank you, Grace. Thank you for that warm welcome. And hello, everybody. Good morning, good afternoon. For those of you who are just waking up, thank you so much for joining this call. I am so thrilled that many of you could join this important meeting, especially during this time when we're really trying to navigate how we can prioritize SBC. And so I'd like to give you a few updates. I'm happy and pleased to share with you that we have new social behavior change working group steering group members, and these are as follows. Next. So the steering group is constituted of 8 members. We have myself, Elizabeth Chiende, and I'm from Zambia. I'm currently the co-chair for the steering group, and Ashley Riley is co-chair from the United States of America. We have Teresa, Dr. Blue. Dr. Blue just recently joined. Welcome, Dr. Blue. Dr. Blue is from Cote d'Ivoire. We have Grace Miheso from Kenya. We have Amu Mudenda from Zambia. And then we have Sus Emiliano from Angola. Benjamin Soro is from Cote d'Ivoire. I would like to say a big congratulations to the newly elected members, who include Ashley Riley, who is joining me as co-chair. And we also have other steering group members, including Dr. Blue, Amu, Benjamin, and for the odd members, as I mentioned, we have Grace Miheso continuing and Sus Emiliano, who's also continuing. Next. So most of you must be aware we've had a great leadership team that just handed over, and I would like you to join me in thanking them sincerely for all their work, all their dedication, the commitment that they put into the working group over the last couple of years. My big thank yous to Mariam Navukenya Wamala, who was co-chair, and she's from Uganda. Gabrielle Hunter was from the United States. Lulu was a steering group member, and we have Mike also from the United States, April Monroe, and Shelby Cash. Thank you so much for the leadership that you brought into this team, and we hope to carry on, and we hope that you can continue to be and continue to support the steering group. Thank you so much. Moving on, I would just like to pass on and open the floor to my co-chair, newly elected, Ashley. Ashley, over to you.
Thank you so much, Elizabeth. It's truly a pleasure to see so many familiar names and faces on today's general call. I know that it's been some time since we've all gathered, largely due to the stop work orders and funding cuts. So I want to begin by sincerely thanking everyone for making time to join us today. It's truly wonderful to see everyone. As we look ahead to 2026, the SBC Working Group Steering Group wants to hear from you. We want to know what we can do to better support you in your efforts and strengthen our collective work in the year ahead. So after today's call, please take about 5 minutes to complete our membership survey using the QR code or link that's on the screen, and I'll also put it in the chat here in a moment. Your insights will truly help shape our path forward and ensure our priorities are aligned with the realities that you're facing. Next slide. Before we move into our technical presentations today, I also wanted to take a moment to acknowledge that it's been a very challenging year for many of us. Across our community, we face challenges, shifting priorities, and reduced resources, and the ongoing impacts of global and local crises. But through it all, we know that SBC remains essential in the fight against malaria. And while it's all too often SBC is the first of the affected areas by shrinking budgets, its role in driving prevention and sustaining control efforts is irreplaceable. So as we meet today, let's take some time to reflect and reconnect and plan how we can have a stronger, more resilient course for malaria SBC in 2026 and beyond. Again, thank you so much for joining us today, and it's now my pleasure to hand the floor to Susan Miliano to introduce our first speaker.
Thanks, Ashley, and hello, everyone. So today we are thrilled to welcome Dr. Peter Mumba and Dr. Oliver Lulembo of the Bridge the Gap Executive Leadership Team. So Dr. Mumba is a global health leader with over 2 decades of experience in epidemiology, surveillance, and health system strengthening. Dr. Lulembo is a Zambian pediatrician and a public health expert with more than 30 years of experience advancing health systems across Southern Africa. While Bridge the Gap presents, please place your questions in the chat. They will be addressed after. And please join me welcoming Dr. Mumba and Dr. Lulembo. The floor is yours. You can start the presentation. Thank you.
A very good morning to you all. Good afternoon to you all. So this presentation will be made by the two of us. My name is Dr. Peter Mumba, and also Dr. Lulembo will focus on the SBCC. Thank you, Chair, to just take this opportunity to thank the RBM for the opportunity to share some of the findings that we have done from the Bridge the Gap initiative. As you may be aware, in 2025, there were several disruptions in malaria financing, particularly as it pertains to the PMI stop work orders and also the Global Fund's reprioritization, which created an urgent risk across multiple high malaria burden countries. BTG was formed to rapidly support these countries, basically in identifying critical gaps and prioritizing interventions, and also mobilizing alternative financing. Today's presentation is focusing on specifically the role of social and behavior change within the context, and summarizes the most urgent cross-cutting findings from 3 countries, Zambia, Ethiopia, and Ghana. Next slide. Yeah. No, the previous slide, yes. In response to the growing crisis, the Bridge the Gap incubator, which was launched by ACROS, was established to support country-led efforts to rapidly address critical implementation and financing gaps in malaria programs across 5 high malaria burden countries, which are Ghana, Ethiopia, Nigeria, DRC, and Zambia. The initiative was launched shortly after the March 2025 announcement of the USAID shutdown and was led by co-executive leadership composed of former USAID and CDC and global malaria experts. BTG also receives strategic guidance from the board of directors, comprising global leaders in malaria control and international development, who are also enthusiastic about supporting and participating so that we can work together. So this is the BTG executive leadership, which comprises 3 members. I am the executive director. I think as per the introductions. Then we've got Dr. Lulembo, who is a pediatrician, but also former PMI advisor for Zambia and Malawi. Then we've got Dr. Paul Saikas, who has been working on the continent for a long time. Dr. Saikas was a PMI resident advisor for Ghana and also Zambia. We have also got Dr. Anna Winters, who is an epidemiologist. And then we've got Ben Winters, who is an expert in informatics and also co-founder of Acros. So these are the countries where we are working from. We are working in collaboration with the malaria programs in Ethiopia, DRC, Ghana, Nigeria, and Zambia. And as you may be aware, these 5 countries represent nearly half of the Africa's malaria cases, highlighting their critical role in the continent's malaria burden. We hope that we can also expand to other countries going forward. Next. Perfect. So what is our methodology? So we use the PMI malaria operation plans and global funds allocation documents to identify key malaria interventions, which were previously supported by these donors. Working with malaria control programs and partners, we determined which interventions would be reduced or unfunded for 2025 and 2026. This was conducted from March to October 2025, during which major budget shifts, including the PMI Foreign Assistance Review and the Global Funds reprioritization exercise. BTG efforts are highly granular, providing very focal country precision to the table and complementing global aggregation level efforts by RBM. This work produced a country-specific gaps, inventory and prioritization tool outlining activity level budgeting, partners, status, finance gaps, and priority level and mitigating options for 2025 and 2026. Next slide. So these are the summary findings that I'm going to share with you for these only 3 countries. We are yet to look at Nigeria and DRC. So as you can see, overall, the gap for Ethiopia in total was about $31.8 million, which was cut for both PMI and global funds, which translated to about 22%, 22.5%. As for Ghana, it was about $34.8 million cut, accounting for about 31.4%. And then Zambia finally was about $24.92 million, which was accounting for 22% reduction. Going forward, I'm inviting Dr. Oliver Lulembo, who's going to take us through the SBC specifically. Thank you so much. Dr. Lulembo, over to you.
Good morning and good afternoon, everyone. I also wish to express my appreciation to the organizers for this opportunity to present on behalf of the BTG. As introduced, my name is Oliver Lulembo, and I'll walk you through the next set of slides. And thank you very much, Peter, for laying that wonderful groundwork. So let's see what the BTG findings on SBC reveal. And thanks, Amo. So let's begin with Zambia, where SBC funding was reduced by 71%. 71%. This major cut poses a serious threat to sustained malaria control. Next slide, please. SBC is among the interventions most impacted by budget reductions. With funding reduced by 71%, as noted earlier, this is equivalent to $4.2 million. Next slide. Now, shifting from Zambia to Ghana, here we see a notable exception. The overall reduction in SBC funds was only 11%, much, much lower than in other countries. Thank you. In Ghana, PMI completely zeroed out its $2.3 million in planned SBC funding. However, the Global Fund stepped in and significantly increased its own SBC budget, largely offsetting the PMI gap. The result was an overall shortfall of just under $267,000. Next slide. Moving on to Ethiopia, the country faces a substantial 67% cut to SBC funds, as well as reductions in surveillance. That was too fast, Amo. In surveillance and entomology. The trend underscores a shift in donor priorities of moving resources away from the long-term systems and innovation toward short-term commodities like rapid diagnostic tests and ACTs. Next slide. Ethiopia urgently needs short-term bridging finance to sustain multiple life-saving areas, as seen in the slide, and an additional $2.81 million is required to resume the halted SBC efforts. Next slide. So, having reviewed the significant funding gaps in Zambia, Ghana, and Ethiopia, the critical question is, why is SBC so uniquely vulnerable to such severe commodities and measurable biomedical outcomes over softer, longer-term cross-cutting interventions like SBC? Second, SBC activities are often classified as non-core. Consequently, when funding is limited, SBC is the first to be paused or cut, despite being fundamental to achieving high and sustained uptake of biomedical interventions. Next slide. Our critical role as BTG is to work with the ministries of health, partners, and donors to precisely assess and define the funding gaps at the country level. Right now, our focus is on building the evidence base, compiling data from the Global Fund, from PMI, and from other sources to generate comprehensive white papers that clearly outline funding gaps and prioritize interventions. This is a country-led process, as Peter says, across the 5 focus countries, and the white papers will be updated as new information emerges. As you know, this is a very fluid situation that we are in. Looking ahead, we plan to leverage, thank you, the white papers to improve visibility and prioritization of funding streams. We also plan to provide direct support to countries to help the ministries of health with their planning, prioritizing the incoming incoming Department of State funding, as well as advocacy efforts. And lastly, we also plan to extend this approach to additional countries. Next slide. Next slide. Finally, how can we strategically, please, previous slide. Thank you. How do we strategically reposition SBC to secure its funding and impact? We all recognize that SBC is essential for enhancing and sustaining malaria interventions. However, despite its critical role, SBC faces a persistent challenge. It struggles to attract investment when packaged as a standalone intervention. Because in today's funding climate, anything not immediately characterized as life-saving is at risk of being deprioritized. We therefore recommend repackaging SBC as a necessary input embedded within core interventions like vector control and case management, rather than presenting it as a separate and therefore vulnerable activity. A key precedent from our experience with PMI funding is that when SBC was integrated into IRS, or indoor residual spraying, the SBC activities were preserved alongside IRS activities and were not subjected to budget cuts. That affected other standalone activities. Next slide, please. Next slide. Yes, and just ready to note that all our publications, including the white papers for Zambia, Ethiopia, and Ghana, as well as webinar proceedings, and we've had 2 so far, are available on the Malaria Across website. And the Nigeria and the DRC white papers are expected to be published in the first quarter of 2026. And the QR code that you see there is active, so please feel free to scan it. Next slide, Amu. And finally, a big thank you to all the partners who made this work possible, the participating ministries of health, our advisory board members, and our key team members, namely Mr. Presley Msonda from Zambia, Mr. Shelemi Tujuba, Ethiopia, Ms. Aden Saravis, USA, and Ms. Carol Milambo Mufana, Zambia. And the key message as I conclude is that without sustained investment in SBC, even the strongest biomedical interventions cannot achieve their full impact. And that brings us to the end of the BTG findings on SBC. Thank you very much for your attention.
Over to you, Chair. Thank you so much.
Thank you. Thank you so much to Bridge the Gap Initiative for this wonderful overview of the challenges that are being faced, and not only focusing on the challenges, but focusing on the SBC recommendations and next steps that we can all consider in our work. I will now pass the floor over to Pauline Wamulume, who will be presenting on behalf of the Zambia National Malaria Elimination Center. Pauline, one moment, let me find my place. Pauline Wamulume is a seasoned SBC practitioner and principal IEC officer at Zambia's National Malaria Elimination Center, with over 2 decades of experience in health communication. She has led major national strategies on malaria and Ebola, supported by the World Health Organization reviews across Africa, and served on the Rollback Malaria Communication Community of Practice Steering Committee. The floor is yours, Pauline.
Thank you, Ashley, and A big thank you to Dr. Lulembo and Dr. Mumba and team for really amplifying the importance of SBC. So I am glad to share with everybody, members on the call, Zambia's experience in sustaining SBC interventions or activities in a situation where you are faced with limited or reduced resources, funding for that matter. Next slide, please. So just to share with you the vision of our country as embedded or espoused in our strategic plan, the National Malaria Strategic Plan, we as a country aim to have a malaria-free Zambia. And our mission is to provide equitable access to cost-effective, quality health services as close to the family as possible. And this is where the community really comes in, ensuring that the community access services without covering long distances. In terms of the strategic directions, we have 3 clearly highlighted in our strategic plan: lowering the burden in high transmission settings, eliminating malaria in low transmission settings, preventing the reintroduction of malaria transmission in malaria-free health facility catchment areas. Next slide, please. In terms of the placement of health promotion, in this case, SBC, it is clearly stated in our strategic plan that it is an important component of the malaria program, alongside the other interventions, which include vector control, case management, parasite clearance, surveillance monitoring, evaluation and research, health systems capacity, and financing. So you will see that health promotion is a priority intervention. Social and behavior change is a priority intervention, clearly stated in our strategic plan. Next slide, please. Again, as you can see, in terms of policy priorities, it is clearly stated in our strategic plan that the SBC component of the program is a priority for the program, for the ministry, and for the country at large. And in terms of ensuring that we increase community uptake and correct use of the key malaria interventions. Next slide, please. So given the situation that arose as a result of the budget cuts, as a program, we are fearful that the indicators that have been on the increase or have improved over the years are likely to go down or reduce or be affected if funding, if SBC activities are not maintained or strengthened. And our malaria indicator survey for 2024 showed very impressive results in terms of awareness, in terms of practices with regards to utilization of nets by pregnant women and children under 5, as well as the general public. And so with the current situation where the program is facing constraints, challenges with funding, I'm afraid the indicators might be affected in the negative. Next slide, please. Next slide, please. Thank you. Just to demonstrate the prioritization of our SBC component and also the value that government attaches to SBC, the Ministry of Health National Malaria Elimination Center budget does have a predictable funding and a dedicated budget line. I must mention here that it may not be what we desire to have in terms of the funding for optimal implementation of activity. However, we are glad that there is this predictable funding which is channeled to the malaria program on a monthly basis to support implementation of SBC. In terms of the adequacy, that's something that we really need to begin to work towards, ensuring that this budget line is increased. But for now, we do have this budget line which we receive on a monthly basis, which is a good sign. Next slide, please. Dr. Lulembo and Dr. Mumba alluded to the funding loss that we suffered as a program. And just to emphasize that in 2025, this year, we lost about 28 million US dollars. Sorry, US dollars. And these resources were being channeled through 4 main projects, which ceased to operate arising or following the budget cuts that were announced by the US government. So this is quite a substantial amount of money, and you will agree with me that it was quite a blow for the SBC family, especially that we already are experiencing low funding from government as well as other partners as well. So in terms of the SBC, out of the 28 million, we lost about 2.5 million US dollars, which was meant for most of the interventions we were implementing. Next slide, please. Next slide. Thank you. And so this is just to share with you the implications as regards the funding gap. And based on this, we had to make very hard decisions to ensure that SBC activities continue to be implemented at all levels of service delivery. And some of the decisions that we had to take meant that we needed to prioritize and ensure that the activities are maintained. So one of the decisions that we made was to ensure that we use mass media and focus also on community engagement. And these interventions have sort of given us very good results and also tend to be cost effective. In terms of, just before that, previous slide, I just wanted to emphasize that based on the decisions, we had to ensure that the high cost events and a number of programs on the African continent will attest to this, that we do have high cost events that gobble a lot of resources, such as the World Malaria Day and other campaigns. And so the program decided that we needed to scale down on high cost events and other general campaigns and focus on cost effective interventions, high impact and cost effective interventions. Next slide, please. And so, having been faced with this rather gloomy picture in terms of our SBC, we made the following decisions and actions to ensure that we continue to sustain SBC implementation of activities. The first one was to focus, as I earlier mentioned, on high impact and cost-effective activities to ensure that we increase correct use and consistent use of interventions. This is very important. We need to continue increasing the uptake as well as the utilization of these interventions. And again, we had to make a decisions in terms of which ones should we focus on in terms of promoting, creating demand using SBC. We settled on the key vector control interventions being the NETs, the ITNs, IRS, which is indoor residue spraying, and added to that, we used our data to look at any other program area that was that needed to be promoted to ensure that we reach our targets. And ANC attendance, though the numbers are quite high, we still felt that we needed to continue to ensure that we maintain the number of pregnant women that attend antenatal. And when we have high attendance of antenatal, and then our IPTP will consistently continue to be high. The second decision we had to make was the use of data for decision making. This is very important when you are faced with reduced funding. The reason we need to use data is simple. The data does not lie. If an intervention is poorly performing, the data shows that we are performing poorly in a certain area, definitely we need to make that decision to invest in that area and ensure that poor performing indicators are improved, and work towards improving those indicators and continue to maintain them to meet national targets. For Zambia, we have two indicators that have really been problematic. The health-seeking behavior has not really been optimal or as expected. We are improving as per 2024 malaria indicator survey. We have increased. However, we still need to increase it further. And then the second one is on IPTP 3+ doses. Again, there's a little bit of work there. The data is showing us that we are not, we haven't yet met the targets. And so as SBC team, we feel that we need to exert our resources, our energies to ensure that poor performing indicators are addressed as we continue to look around for additional resources. We also feel that we need to maintain indicators that have been consistently high. And for Zambia, we've had the indicators on knowledge, which have consistently been above 90. If we slacken and we do not continue to implement activities that raise awareness, that increase knowledge, we may face a situation where the knowledge levels will go down. And once knowledge levels go down, that simply means that the practices, the indicators on practices, attitudes will definitely be affected. And so it is very important that we make that decision to maintain indicators that have been consistently high. Other decisions that we made were to look at low-cost channels of communication based on evidence. And for Zambia, evidence has shown that community radio is preferred, and most of the times the costs for hire or airing of radio programs tends to be a little bit cheaper than television. And so these are some of the decisions that we had to make. Again, just to amplify the use of data, our 2024 malaria indicator survey shows that radio, health workers, and community health workers are preferred sources of information. And so as we strategize and plan SBC activities, we have to take this into consideration in terms of where do we invest, where do we put our resources to ensure that we have greater impact. And lastly, on this point of using data, we are very happy that across and the BTG team were able to develop the white paper, which will be a very important tool in our decision making. More so that we are going into the grant application for the Global Fund, Cycle 8. And as you know, this process is really heavy on evidence. And so the white paper, the malaria indicator survey, and any other research findings will really play a key role in shaping the SBC component that will be part of the next grant. I seem to have lost the slides of Amo. Can you hear me, Amo? The slides, I'm not able to see the slides from here. Sorry about that, colleagues. Sometimes technology can challenge us.
Well,
thank you.
slides back up. Just noting that we are starting to run out of a bit of time. If you can speed up through your slides a bit, Pauline. So sorry. Thank you.
Okay, no problem. The other decision and action that we needed to make was to ensure that we combine traditional and digital strategies for impact. And this involved making decisions on what we utilize, mass media, digital platforms, production of mini documentaries, and also having digital launch of malaria events. So combining the traditional and digital strategies. Next slide, please. Integration of activities for maximum impact is also another decision that we had to make. As you know, resources being scarce, we had to look at the different disease areas, thematic areas, and look at opportunities for integrating or implementing activities at the same time to save resources. Most importantly, we decided that strengthening of partnerships and collaboration needed to continue, including joint implementation of activities. We have created new partnerships with the Zambia Medical Association and also leveraging on existing partners such as the private sector, CSOs, NGOs, and all the players within the malaria space that have additional resources to ensure that they support the program. These are just some of the examples that we wanted to share with the team. You can see that we have our youths. If you look at the picture below at the bottom, those are our, what we call the Zambia Youth Corps, who essentially do a lot of SBC at the community level. These are young people. And through the End Malaria Council, important group of young people who are really helping us out. Next slide. We continue with strategic partnerships and collaboration. We have been working closely with FLAME, which is the Faith Leaders Advocacy for Malaria Elimination, really bringing together all the faith leaders under one umbrella and equipping them with information and key messages that they can in turn disseminate to the congregates. Next slide, please. I can speed up now. These are just examples, so just sharing with colleagues on the call to see exactly what we were able to do. So I continue with strategic partnership and collaboration again, working with the Ministry of Agriculture, National Agriculture Information Services. We were able to leverage on their comparative advantage, those advantages being the fact that they have a studio, they have airtime on television. They do have columns in our daily papers. And so we continue to collaborate with them in the production of some mini documentaries. Community engagement, advocacy, again, we have continued to engage the civic leaders. So far, we have oriented about 900, and out of that, they have been able to develop community action plans. Next slide. Next slide. Yeah. Again, one of the decisions that is working for the program, previous slide. The previous slide, please. Yes. So we are maximizing on the use of digital platforms. As you know, we are in a digital era where everybody is using Facebook and all the other social media platforms. Next slide, please. Next slide. One may ask, how do we integrate malaria activities? How has it worked for us in terms of Zambia? So we have been conducting joint monitoring activities, vector control, SBC, moving as a team to ensure that all the activities are conducted on time. Demand creation during health events, any health event that is held, malaria program is always invited. Moving forward, this is my last slide. I just want to share with you some of the challenges without going through all of them. Some of them have already been, mentioned by Dr. Lulembo. The funding and also other resources seems to be inefficient. Low prioritization of SBC by sub-national levels, specifically the district budgets. The allocation of funds for SBC has been consistently low, mostly below 15% of the malaria budget. And the inadequate focused behavioral related studies, again, these seem to be not prioritized. Most of the times we do the general kind of malaria behavior survey. And so in terms of recommendations, we highly feel that resource mobilization needs to be intensified. We need to lobby districts to increase their funds for SBC implementation and, of course, develop SBC research agenda and commission studies that provide evidence and demonstrate the impact of SBC on malaria-specific interventions. This is my last slide. I want to thank you all for your attention.
Thank you. Thank you very much, Pauline. And also thank you to the Bridge the Gap team for sharing these valuable and really practical solutions, valuable experiences and practical solutions with the SBC working group today. These presentations come at a critical time as the changing funding environment challenges us to find new ways of sustaining SBC and the progress we've made in saving lives. So again, I want to thank you, Dr. Lulembo, Dr. Mumba, and Pauline Wamalume. Those were really, really exciting and very interesting findings. So now we'll quickly move on to the question and answer session. And thank you for your questions and comments in the chat. We really appreciate them. Please continue sending them in. I know one presentation that was really asked about was having copies of the slides. We will share them with you. And these are really a good resource that you can all apply to your countries. So that will be very interesting. So moving on very quickly to the questions. We have one from Sean, and this is to Bridge the Gap initiative. Is there anything we can learn from Ghana and their ability to replace SBC findings with global fund investment to bridge the gap that we can apply to future SBC advocacy efforts? And of course, I will just also ask another one also to BTG, and that was from Helen, who really wanted to understand that there has not been much time to see these outcomes. When we think about the experiences in Ghana versus the countries with large SBC funding gaps. So what are some anecdotal evidence that we can share? So we can have some response from BTG, and then we can move on to some questions for Pauline. Thank you.
So thank you so much for the question, Grace. I think the first question, about the first question, we are having a meeting with the National Malaria Program in Ghana tomorrow in the afternoon, and we will be able to get some of their responses. So I think at this time, probably we may shelve that question, and we will be able to get back to you. Thank you so much. I think as for Ellen, we will be sharing some of these results that we've done, because we were waiting for the national program to review some of the results that we found and then get back to us. And that's what exactly we are doing tomorrow. So once we get these, we should be able to share with everyone. Thank you.
Peter, Grace, this is Paul. If I may come in on this question. Good. Yeah, just
please go ahead.
Yes. Go ahead.
Yeah, good. Ghana was fortunate to be able to find some resources in the Global Fund grant and move it over to cover PMI gaps. But I think if you look across countries, Ethiopia and Zambia's experience will be more typical in that, as the president has said, under the Foreign Assistance Review and the new U.S. government priorities, it's really those life-saving humanitarian assistance, the BEDNET campaigns, the IRS campaigns, prompt diagnosis and treatment. They're getting the prioritization as funds are coming back on currently, and potentially also with the new Department of State funding mechanisms coming up. So again, Ghana was in a particular situation, but in most cases, I think we'll find that the countries themselves, the Global Fund, are really scrambling to fill very urgent gaps, for example, in reductions of ACTs, RDTs, and so on. And so I think it'll be more typical to find that SBC sort of on the chopping block. And one point we really wanted to stress today, it doesn't come across so much in our white papers, but it was something we came up with as we were thinking about what this group, this working group may want to hear, is kind of that tactic that we recommend. It's hard to swim upstream. The new currents are really looking skeptically at SBC as a cross-cutting standalone activity. And if those of us who've worked on the MOPs, the malaria operational plans over the years, when you think about from the donor perspective, how can Global Fund, PMI, others be encouraged to fund SBC? We're finding that the old days in the MOP, where we had sort of these standalone items and standalone projects like a breakthrough action, a PMI insight, sections of the malaria operational plan, specifically in SBC. These are kind of vulnerable and are targeted. But as Dr. Lulembo pointed out, when we find that SBC is embedded in a life-saving humanitarian activity like IRS, it kind of slides through. It's sort of like, well, we need logistics, we need planning, we need data, and we need SBC, just part and parcel. So it doesn't sort of stand out as something that can be cut. And so perhaps another example is community case management. We've seen in Zambia a series of projects, including PAMO. If those of you who may know PAMO, a PATH project, their SBC community mobilization was sort of embedded in the work planning around community case management. And that just tactically speaking, it may be a safer, more effective way to go. So it's something we wanted to share with this group. Thank you.